Hey, everybody. Welcome to the last session of the day. As a quick reminder, in order to receive a certificate of attendance, you'll want to fill out this survey. We'll post that in the link in the chat at the end of this. Once the series ends on August 28th, we'll send you a certificate with the number of hours you attended. For this presentation, please put your questions in the chat or Q&A box, and Dr. Lutz will address them at the end of the session. Additionally, the slides will be posted on our website within the days following this presentation. I'm Justin Mauger. I'm the Eastern Washington Community Health Educator for the Washington Poison Center. I first heard Dr. Lutz speak on the issues surrounding substance use at a citywide opioids town hall event. He is beloved by service providers in our area, in part because of his recognition of societal factors that contribute to health inequities and his deep commitment to improving the lives of everyone, especially those challenged to do so for themselves. He has served in multiple community health leadership positions for many years and currently works with Community Health Associates of Spokane, commonly known as CHAS Clinics, which is an Eastern Washington federally qualified health center as a street medicine provider working with our unhoused population. So Dr. Lutz, thank you so much for giving us your time and presence today, and I invite you to please take it away.
Justin, thank you for that very kind introduction, and good afternoon, everyone. So Justin, first slide, or abracadabra, whatever we're going to use as our next slide. And I'm talking to you from my backyard, so the shadows are, again, what they are. So next slide, please. Next slide. Learning objectives. Next slide. So I think it's interesting, like so many illicit substances, they have their beginnings somewhat inauspiciously. And methamphetamine was actually first discovered chemically back in the late 1800s in Japan, crystallized meth in 1919, and then amphetamines, a sister product, if you will, in 1880s. In the US, there was a scientist experimenting, looking at it, and Gordon Alls is, again, someone who was given the, just lost the slide, was given the patent for amphetamines, and he partnered with SmithKline French, which was a Philadelphia-based pharmaceutical company. Next slide. There we go. An interesting font change is interesting. So anyway, he was able to get the patent for the drug and partnered with SmithKline French, which became SmithKline Wellcome, I believe, to really move the drug across the states. But it really became incredibly popular during World War II. And again, just a lot of historic notes about this drug. It was known by the trade name Benzedrine, which was how it was founded by SmithKline French, primarily as a medication used for asthma. But it was quickly found that it had other effects. And it was those effects that really brought its popularity to play in the 1930s. Next slide. And so, next slide. And so what's interesting to note is at that time, these medications were not prescription, so they could be bought over the counter. And so SmithKline French did a very nice job of marketing this, marketed to populations such as college students, such as young people. It became, if you will, the muse of the beatniks in the 50s. As I said, heavily used during World War II and during the wars by both Axis and Allied forces. And it was really very popular. So the term, next slide, bennies, became sort of the slang word for Benzedrine. And as I mentioned, used by a lot of different groups. How it, at some level, became a very popular illicit substance was its heavy use by California biker gangs. Next slide. And so just a comparison, if you will, chemically, you'll see that amphetamine and methamphetamine, very, very similar chemically. There's just a little bit of a difference in its chemical structure. And currently, because of the fact that it was identified as a substance of abuse It was identified and created as a Schedule II stimulant. Limited use right now with obesity, with ADHD, narcolepsy, and obviously its illicit use is considered just that, illegal. Next slide. And I do apologize about some of the slide formatting. It doesn't necessarily pass through. These are just some other drugs that are similarly related. MDA known as ecstasy. I'm sorry, MDMA is ecstasy, and MDA similar chemically, slightly different effects. Definitely have many, if you will, psychedelic/psychogenic effects. But this group of substances, because of the way they work at the neurological level, have unfortunately become substances of abuse. Next slide. So yet again, formatting issues. So again, we all know these prescription medications, Adderall certainly and Ritalin, are very, very commonly used. But again, just some other prescription amphetamines. Let my dog go away. Diego, go. He's hearing me talking, so he wants attention. Next slide, please. And so how do they work? They all work by essentially overloading the synapse with these sympathomimetic amines. So dopamine, serotonin, noradrenaline. So by a variety of different mechanisms, the postsynaptic cleft is just overloaded with these monoamines, and they then, based upon the pharmacology and their effect, they cause the variety of symptoms, both at the central level as well as at the peripheral level, especially with the cardiovascular system. Next slide, please. So as the slide says, primarily they're metabolized by the liver. They tend to pass through the system fairly quickly, albeit depending on how people are frequently using the medications, you may have urine levels up to 7 days. But again, a fairly rapid pass through. And what we see is that irrespective of people using the medications chronically, the metabolism is not so much impacted by that, but rather by how these medications are broken down. Next slide. So so again, the acute subjective effect tends to diminish over time. That's why people tend to use them frequently. Dosing patterns, oftentimes in binges, unfortunately. And it seems as if, again, the common dose is anywhere between 30 and 50 milligrams, although obviously there are excesses, especially for people who develop tolerance. And you may see people using up to 4 grams a day and having, unfortunately, all the untoward effects, both desired as well as undesired, from those heavy doses. Next slide. So just a slide just sort of showing you, I mean, you can see that its half-life is measured in hours, whereas it hits maximum level within minutes. And especially if it's done intravenously, or now how the majority of people are using meth, smoking it, it nonetheless causes effects within a very short period of time. Next slide. Next slide. I think it's really important to put context of substance usage, why people use drugs. And, as I've come to say, people use drugs to feel good and to feel better. And again, I apologize about the formatting of these slides. So essentially, people want to feel good. They want to feel differently. Okay, they want to have a unique sensation, but they also want to feel better. Again, we have to understand that substance usage is very much a contextual type of situation. As Justin said in the lead-in, we have to understand the conditions in which people live, work, and play, and survive at times, as to why people use drugs and sometimes, unfortunately, become addicted to those substances. Next slide. So again, just a variety of different elements that bring this all together. And you can see social, psychological, obviously there are biological components, environmental, and then certainly cultural. Next slide. Yet another slide just demonstrating the same thing, and I emphasize those elements on the right. You may have a genetic predisposition, but unless the environment, unless there are elements of the situation in which you live that present your unique physiology with that risk, you may not develop substance use disorders. And we have to look at those issues, those cultural issues, ACEs as an example, adverse childhood experiences, as being very impactful on a person's predisposition and therefore progress into having a disorder. Next slide, please. Next slide. So just street terms for meth. Again, you know, it's interesting, crank, you've probably heard of that. And it's interesting, crank actually came, as I alluded to earlier, that very popular with LA biker gangs. And so they would hide meth in the crankshafts of their motorcycles. Goofball, it's a combination of an opioid, oftentimes heroin in the past, now fentanyl, plus methamphetamine, or some sort of speed, like, for example, cocaine. Next slide. So just a quick history, and there is a reference that that's at the end of this that just sort of provides for you an appreciation of how this has become such, unfortunately, a popular illicit substance. So amphetamine, key chemical compound, is phenyl-2-propanone, P2P is how you'll oftentimes see it. And they realized that as they were readily able to make it from ephedrine and then Sudafed found in cold medications. And so there were efforts by the DEA to regulate sales of over-the-counter cold medications, but not surprisingly, pushback by pharmaceutical industry because cold medications were major moneymakers. Nonetheless, in early 2000s, there was an actual act that required many of these substances, these cold medications, to be behind the counter, no longer OTC. And what that prompted was, not surprisingly, a change in the way these substances were being made. Next slide. So a nice little time line of how this has progressed. So again, in 2005, 2006, we saw efforts by the FDA to regulate. Sharp drop, precipitous drop in meth availability, but nonetheless, cooks realizing that they had other means by which they could make methamphetamine. And where we see right now is that, if you will, they at times call it super meth. We have a lot of the substances coming in from and made in Mexico and brought to this country. And it's, again, become a scourge for all of our communities. Although certainly we've been focusing a lot on fentanyl, and not inappropriately so. As I mentioned in my header, this is the forgotten drug that is still out there and very, very commonly used, and oftentimes mixed with other drugs. Next slide. So this is just a slide showing how, again, just a simple synthesis, if you will, going from P2P, simple compounds with Sudafed, for example, and making it methamphetamine. Next slide. Oh, I'm sorry, Justin, go back if you will. I apologize. That's the link. If you could go to that, just click on that link. This is a, if you will, sort of a, I'll use the term fun, sort of in quotes, interesting way of looking at how simple it is to make and cook methamphetamine. If you could hit that link. That's not quite the, yeah. It's the header at the top of the slide. There we go. If we can get to play for a couple minutes. We love technology until we don't love technology.
1970s, the Pied Piper of meth, they called me, you know, these little children down the path.
It's a nice day in Green Bay, and we've got some veterans coming off the bench for the first time all season. Baxter begins his synthesis of nitroethane with the drying of ethanol from grain alcohol. A volumetric flask is charged with 1 liter of 95% ethanol, insulated with aluminum foil, and heated. Methylethyl ketone is added to entrained water in a positive azeotrope, allowing it to be distilled from the ethanol.
She's distilling.
First down. 93% sulfuric acid is poured into a stoichiometric excess of dry ethanol and gently boiled. Sulfuric acid protonates ethanol's oxygen, forming an ethyloxonium ion that participates in an SN2 reaction. The oxonium leaves water, and the sulfate attacks a carbon, producing ethyl sulfate. But the rapid addition of sulfuric acid and high temperature allows subsequent SN2 reactions that form diethyl ether, which boils from the reaction mix, and the probable human carcinogen, diethyl sulfate, a menacing side product recognizable by its wintergreen aroma.
Green-based DNA just got alkaline.
The deep red crude ethyl sulfate is removed from the hot plate and poured over ice.
All right, now I can start adding my powdered limestone.
Oh, got the ice cream.
That's exactly what it
Adjustments.
is.
An unknown quantity of ethyl sulfate.
You know what I was trying to make you aware of the fact is that as the FDA has attempted to regulate historically elements that would go into making meth, not surprisingly, we've been able to find other ways. And let's go down a couple. There we go. Yeah. So what's happened is, again, you know, through using a variety of different chemicals, household products, they've been able to make meth. And also acknowledge, and again, I'll mention this later on, but right now, whereas, you know, back in the 80s and 90s, we had a lot of labs, and if you will, clandestine drug labs that were making this. Right now, it's not even that commonly done. It's coming in from Mexico, pre-produced and or easily available. And so there's not as many of these labs as we used to see in the 80s and 90s, but rather just meth unadulterated, I should say adulterated, coming in and ready to be sold on the streets. Next slide. So again, this slide just simply shows how we've seen this incredible surge of methamphetamine coming from south of the border. Next slide. And not surprisingly, as the markets have been flooded, prices have gone down. And just as an example, a hit of meth on the street right now, you can get for, you know, less than $10. Fentanyl, depending on the market, even less expensive. I've heard that in some areas, a pill of it, like what they call Mexis, are selling for like 50 cents to $1. And so what not uncommonly is found is that although many individuals have, if you will, their primary drug, so much of the drug usage currently is based upon availability and cost. Next slide. These are data from what's called the Northwest High Intensity Drug Trafficking Area. And you can see that, again, we have very, very, quote, pure, end quote, meth in the Northwest, primarily coming in crystal. And we're seeing, unfortunately, much more meth in the Northwest than what we're seeing elsewhere across the country. There's definitely, when I look at fentanyl, for example, fentanyl has moved from east to west, acknowledging that meth never went away in the country and has always been highly used in the Northwest. We're nonetheless seeing a lot more, as I mentioned, meth coming in from Mexico, now coming into the area. Next slide. This again speaks to the fact that we have just having comparable rates in Eastern and Western Washington. And we're also seeing, again, these data are coming from a variety of counties across the state. And again, that second bullet for you. Next slide. So as I mentioned, summary of where it's coming from, it's coming through Mexico. And there's a, if you will, a myth or a statement that oftentimes we're seeing things like cannabis, which is legal in Washington state, being mixed with methamphetamine. And to date, that's not what the HIDTA has been finding. Next slide. I want to share some data with you. These are from colleagues at ADAI at University of Washington. They do every 2 years a syringe service program interview, and this particular interview, they had about 1,700 individuals participate. Next slide. Next slide. And so you can see that for many individuals, methamphetamine is indeed their primary drug, comparable to what we're seeing with fentanyl, and very high usages. 90% of the individuals reported using it within the past week. Next slide. Just a variation of the theme, main drug fentanyl, main drug meth, essentially the same numbers, oftentimes combination use, opioid plus stimulant use, about 60%. Next slide. Different way of looking at it. So again, frequent usage throughout the week. Do note, however, that we're seeing, like, look at heroin, no use in the past week, 84%. Cocaine, no use in the past week, 76%. So very, very different markets as compared to a couple of years ago. Next slide. As I mentioned earlier, the majority of people are smoking, but depending upon past usage and availability, many people are injecting and also smoking. But I have definitely seen a shift, as many of you have, who was working with people who are using substances, a real shift to smoking versus injecting. Next slide. So it's important to understand that, as I mentioned earlier, the context in which people are using drugs, if given opportunities to stop using drugs, many people are interested in doing so. Next slide. But it's oftentimes challenged by lack of access to services, resources, what have you. And so you see, again, only 65% of the surveyed group did not have access, were not in drug treatment in the past year. Next slide. And again, this just provides you an appreciation of what those limiting factors are: access, lack of transportation, something people don't realize, but if you don't have a means of getting from point A to point B, and the only way you do that is on your feet, and you don't have a clinic that's near you, you're not going to be able to access services. Homelessness, a huge issue. Next slide. And so when asked, what's the top need and granted, it's a biased sample of individuals using syringe service programs, but 44% of people said housing was their top need, followed by other factors. Next slide. And speaks to itself. If they had stable housing, you have more than 2/3 of the population would either quit completely or decrease their usage if they had stable housing. So I always encourage you, whomever, to look at the social context in which people are using substances. Next slide. This is another survey done by ADAI, and you can see reasons to cut back on the left: family relationships, a normal life, and obviously getting health back. And what would really help them would be, again, that social connection, access to services, and then obviously personal issues, and then housing again comes up as a high priority. Next slide. So just a summary slide of their findings, that again, high prevalence of stimulant use combined with people who are using fentanyl. We need to address opioid use, but we also need to look at it in the context of polysubstance use. And as we'll talk about in a bit, we as of yet do not have good medical treatments for meth. And so we have to look at how we can provide sort of comprehensive services to assist people with addressing their use disorder. Next slide. Next slide. I always like formatting changes. So again, when you look at the short-term effects of meth use, these are some of the common things that are experienced. And if you think about that slide that I showed previously of how meth affects neurotransmitters, especially, and I should say other monoamines that are elsewhere throughout the body, it's not surprising that many of the effects of these substances are at the cerebral level and at the cardiac level. So these are just some of the common things that you'll see from people who are using meth. I emphasize abscesses and cellulitis. Probably the most common thing I see when I'm doing street medicine is people coming in with a variety of skin-related issues. Not as much as in the past, because again, as I mentioned, people are not necessarily doing IV injecting or muscling, but nonetheless very common. Again, long-term effects, dependence, changes in the neuroanatomy and function. You'll find people, when you talk with people who have been using meth for years, that there's a definite difference in how they're mentating. Psychosis, not only acutely, but chronically. Some other things that you'll see in long-term effects. Next slide. Additional long-term effects. One of the very, very common things you'll see is what's called meth mouth. It ends up basically, destroying people's teeth, especially their front teeth, which makes it very, very difficult for these individuals when they are able to successfully stop using to enter back into society, because they have this very obvious stigma with, again, blackened teeth. But chronic skin picking, delusions of parasitosis. I remember probably the very first individual I saw 30 years ago using methamphetamine brought in a manila envelope filled with pieces of Scotch tape, to which were affixed anything from dust to fibers that she was quite confident were parasites that she was picking out of her arms, legs, and abdomen. Some other long-term effects. Next slide. Very concerning use during pregnancy. Certainly you're familiar with, and if not, should be familiar with, the increases in syphilis over the past decade plus, whereas in the past 2 decades, it's been primarily in an MSM population. We're seeing this much more in a heterosexual population and a bisexual populations than in the past. And unfortunately, during pregnancy, it causes significant problems, not only being able to hold on to the pregnancy, but also if the child is born, we'll see a lot of fetal changes, as I mentioned here. And then next slide. Those changes unfortunately continue on through infancy into childhood and adolescence. Next slide. A couple terms here. Tweaking. Tweaking, you've certainly maybe heard of the term tweakers, but what happens is with significant use, and you're having people use multiple times throughout the day, it obviously, as an amphetamine, keeps people awake. And so they have pretty profound sleep disturbances, and they're always looking for that first high. And so you're going to continue to use to try to get that sense, that feeling back. But then when you can't get it back, you get angry, you get frustrated. And so you use more, which then leads to unpredictable behavior, violence, high rates of domestic violence, spontaneous offenses. What's interesting when you talk with somebody who's having this experience is that they may actually sound normal. And yet when you're talking with them, they just tend to veer off. They become a little bit more tangential. They start a little bit weird. You'll notice maybe their eye movements are very, very rapid. They will not look at you. They're like looking back and forth and back. Just interesting. And then again, oftentimes to kind of try to quiet down that mental state, they'll use a sedative such as alcohol or opioids, which unfortunately oftentimes exacerbates their underlying psychosis. 2 weeks ago, I found myself in a situation where, in hindsight, the person was definitely in one of these states. And we came upon him trying to provide some assistance to him. He pulled out a shank, which was a little bit disconcerting to the people I was working with, myself included. And we drove off knowing that there was not much we could do at that point. So just Again, extreme caution when you're finding yourself interacting with individuals who are, quote, tweaking, end quote. Next line. Overamping is another term. It's used somewhat relating to people who are, if you will, overdosing with methamphetamine. And so you see both a constellation of psychological as well as physical effects. Next line. Risk factors include using higher doses than what you're comfortable, what you typically do. Lower tolerances. Unfortunately, we see this not uncommonly when people have been incarcerated and then released. They've lowered their tolerance and they're much more susceptible to an overamping phenomenon. Sleep deprivation, again, frequent usage, just changing your space when you're someplace else with people that you don't know versus being in a comfortable setting with others that you're commonly using with. And so we always encourage people to use with people you know and to use around other people. Mixing, and then as I said, underlying physical health, and excuse the dogs in the background. Next slide. So how does meth intoxication present? Again, dilated pupils, mental status, acute psychosis. People may present with strokes. They will oftentimes be tachycardic and high blood pressure, especially due to, as I mentioned earlier, with mechanism of action, a flood of catecholamines. Conversely, in some situations, you've so flooded the system in the past that you don't have that resource, and so you may present with just the opposite, bradycardia and hypotension, low blood pressure. Next slide. Abnormal heart rhythms, chest pain. It certainly can precipitate cardiac and myocardial infarctions, heart failure, especially if you have underlying heart disease, pulmonary edema. These can be very life-threatening presentations. Just the system basically just shuts down, and so you'll have sort of collapse of the cardiac system, the pulmonary system, neurologically, for people who are experiencing overdoses. Next slide. Real quickly, I mean, for those who are in the emergency room or clinicians, these are sort of things that you're probably familiar with, but if not, benzodiazepines, you may require increasing doses, not just a single dose, but rather keep on providing benzodiazepines to kind of slow down the processes, antipsychotics for the agitation. I like this idea, what they call a B52, which is Haldol, an antipsychotic, plus Benadryl, diphenhydramine, plus a benzodiazepine. Excuse my dogs, they're very excited. And then just to address some of like the cardiac manifestations, labetalol, which is an alpha and beta blocker, or metoprolol is a beta blocker, can also be used to address the intoxication. Next slide. Providing you some more data. These are from colleagues at Department of Health, and specifically looking at overdoses related to stimulants. Next slide. So you can see, certainly, if I compare Washington State to the United States, and specifically focusing on psychostimulants with the dotted line, you can see that Washington rates of overdoses are significantly higher than that at the national level. Next slide. Certainly an escalating rate and number over the past couple of years. Next slide. If I look at it by quarters from 2018 through 2024, noting that 2024 data are very preliminary, nonetheless, you can sort of see that the numbers have certainly been bumping up over the last couple of years, going from 2018 through 2023. Next slide. As I shared in the title, psychostimulants have not gone away. Certainly our rates are much higher for use of synthetic opioids, primarily fentanyl, but psychostimulants going from 473 deaths in 2018 to almost 1,900 last year that are still preliminary. Those numbers are very concerning. But do note also, as I mentioned earlier, heroin markedly decreased. Any opioids obviously is going to be inclusive of prescription medications, and we see that those numbers have not changed significantly. So any opioids really are fentanyl at this time. Next slide. Just another variation of a way of presenting that. Again, syn refers to synthetic and psychostimulants, so 50%. Next slide. And as this slide demonstrates, the vast percentage, if you look at the yellow, that specifically indicates that individuals on tox screens at autopsy or from the coroner's offices, we're seeing the majority of individuals have multiple substances in their system with psychostimulants, as I mentioned, primarily with synthetic opioids. Next slide. A map just showing across the state where you have very high rates and counts. And you can see, some of the darker are the higher numbers. In contrast, green indicates the numbers are small enough to suppress, but obviously very, very significant, especially in some of our more rural counties in Western Washington and Eastern Washington. Next slide. Although certainly we see it primarily in males, nevertheless, we are seeing increasing rates in females as well. Next slide. By age, it's always interesting for me as someone in the 55 to 64 year range to see that we have some of the highest rates in this age group. And again, I would argue it's because methamphetamine never really went away. It's been around for quite some time. Next slide. And if I look at it by race ethnicity, unfortunately, our marginalized populations, especially Black and brown populations, have some of the highest rates. I emphasize the American Indian, Alaska Native populations, and as well as Native Hawaiian on the left. Next slide. And again, looking at it from the standpoint of combinations. Next slide. Hospitalizations, upper line is any drug, but if I look at it, certainly any opioid, i.e. fentanyl, twice as high, but irrespective, methamphetamine has certainly continued to be increasing over the years. Next slide. Stimulants also with cocaine. Next slide. Treatment, and unfortunately, unlike what we have with opioid use disorder, where we have medications, we really do not have good medications at this time, although we have some encouraging research to suggest that injectable naltrexone and Wellbutrin has been shown in some phase 2 trials to be good. Mirtazapine, actual use of psychostimulants. It's important to realize that maybe 10% plus of individuals are self-medicating. They have ADHD, either diagnosed or undiagnosed, and find themselves using methamphetamine to address and, if you will, be able to kind of keep it together. So looking at underlying issues, do they actually have a pre-existing co-occurring disorder that maybe was never treated and or never diagnosed? But certainly behavioral therapies remain right now the cornerstone of treatment of people with methamphetamine use disorder. Next slide. One of the things that's become challenging over the past couple of years with methamphetamine from a public health standpoint, firsthand exposure speaks for itself. Secondhand exposure, we're seeing this a lot around fentanyl, but it's also just of much of a public health issue around methamphetamine. People with ubiquitous use of these substances, especially smoking, there is residue found in a variety of surfaces. So you may be familiar with the Seattle bus study from a couple of months ago that showed a very high level number of buses that were able to determine that there was actual residue from illicit substances. And so people get very concerned about whether or not that exposure can cause people to overdose, to have untoward side effects. And to date, we've not really seen research, or either empirical or anecdotal, to suggest that that sort of casual secondary exposure causes problems. That's compared to people who are living in contaminated spaces, especially in drug labs and things of that sort, where again, there's chronic usage. And so certainly there is a risk associated with those types of exposures, especially in that there is some dermal absorption, and or especially with young kids, with babies, with infants, crawling, and that hand to mouth type of behavior that makes them much more susceptible to ingesting illicit substances, to include methamphetamine and fentanyl. Next slide. So as I mentioned, third-hand exposure. One of the challenges we're seeing right now from a public health standpoint, as I mentioned, is that going back to the 80s and 90s and even maybe 70s, where you had these drug labs, every state has a statute that talks about a public health response to drug labs. As I mentioned, however, we're not seeing drug labs like we used to, and yet we're still sort of addressing and dealing with that kind of exposure. And so what I know is happening in Washington State as a result of public health being contacted about, quote, contaminated spaces such as apartments, is how do we properly investigate and identify whether or not a space is at risk to people moving into it. If you look at the data that have been used to define some of the levels that would define, quote, contamination, they are incredibly small and very unlikely to really cause health effects. Acknowledging that the data that were being used are data from the 70s with very specific populations, primarily with women and women who were pregnant and maybe with infants. And so those data have created the foundation upon which public health has been called upon to address previously clandestine drug labs, but now spaces where people are using. And as I said, it's caused a lot of challenges at the local public health level. And because of that, many states, to include Washington State, are going back and looking at how to reevaluate and really determine whether or not a space is, quote, contaminated and causes untoward health effects. Next slide. So just a couple of resources specifically to look at that public health response. Next slide. And also where you can find data for substance usage from DOH. Next slide. And some additional resources. And that should be it, Justin. So yeah, let's open it up to questions. Let's see. First question from Jessica. I'm saying, have you seen a spike of people who display psychosis due to meth use in recent years? Again, I would share with you, Jessica, that my experience is probably not long enough to see a spike. But what I definitely do appreciate in talking with people who have been in this world for quite some time is that the methamphetamine right now that's coming in from Mexico is a very different product than what was being cooked decades ago. It's much more potent. And as a result, depending upon people's use patterns and or use history, they may find themselves having many more psychotic episodes. So my sense is that you're seeing many more individuals presenting with, if you will, that overamping phenomenon or demonstrating psychosis because of the nature of the drug they're using and how they're using it. Second question from Marsha, is fentanyl being cut into meth? Great question, Marsha. And everything that I've seen and talking with people said that's not the case. fentanyl and meth are both adulterated with a variety of other substances. Chalk, for example, chalk and baking soda are commonly being used in methamphetamine powder, or with fentanyl powder. And if you look at fentanyl tablets, it's what's oftentimes been referred to as the chocolate cookie effect, in that with illicitly manufactured fentanyl, i.e. IMF, where there is no quality control, quote unquote, you may find in one tablet that looks exactly like the other tablet. And even within that one tablet, you may find parts of it that have higher concentrations of fentanyl than others. So long answer, short question, people that I've talked to have said that it's not fentanyl being cut into meth, fentanyl or meth, two separate products, but oftentimes used concurrently, that goofball combination, or as I mentioned earlier, what's readily available is what people will use. Which method has a faster damaging effect? It depends, I think, on what you're looking at damaging. Certainly, right now, inhaling smoking, we certainly are seeing a lot of pulmonary problems. On Monday, again, I know someone who I've seen regularly who has, quote, chronic bronchitis because of smoking meth. Injecting, we're not seeing as much of, but certainly in the past, a lot more issues around abscesses, infectious diseases, to include HIV, hepatitis C, endocarditis. The first person that I mentioned to you before, who with delusions of parasitosis, she ended up transferred from my practice after 6 months for developing subbacterial endocarditis. And so I think it depends on how you are looking at it, how you're defining damaging effect. But I think irrespective of how people are using it, disproportionately people are smoking right now. It has very significant both acute and long-term effects. Let me go to the chat if I may. Let's see. Thank you. Yes, the postings. Yes, the PowerPoint will be provided. Any other questions?
I had one briefly, if you don't mind.
I just want to, if you will, Justin, I just want to call out Conrad, who just thanked me. Conrad is an incredible colleague and resource for me at Department of Health. The slides, the data from Department of Health were provided by Conrad and his colleague Dana. And so I really appreciate the collaboration and support Conrad and DOH has provided to me in this work over the past number of years. So thank you. Yes, Justin.
So I was wondering, if, say you're layperson, and you suspect somebody maybe that you care about, or someone in your family, someone that's around you, is perhaps overamped or having an overdose on methamphetamine, what course of action would you recommend?
Chill them out. I mean, truly, I mean, metaphorically, try to get them, and again, try is an operative word, but you really want to decrease that stimulation. So if there's a way that you can talk them down a little bit, get them into a safer space, really try to decrease as much all the external stimuli that are keeping them amped up. It's really trying to be there for that person, calm them down, reassure them. That support, I think, is really very beneficial. And then, as I mentioned to, the audience, Justin, I mean, there's that B52 and there's that one over-the-counter component that really works well for people, Benadryl. And so that's not an unreasonable medication if you want to try to provide some medical support. I don't always encourage that, but irrespective, that may be of some benefit to the individual. But really try to just get them to relax, support them, and ultimately prevent them using methamphetamine again.
How does the cost of methamphetamine compare to other substances that people are using?
Currently, as I mentioned earlier, Justin, fentanyl is so cheap.
Mhm.
You know, I was hearing a couple months ago where fentanyl was, a Mexi was costing 50 cents, whereas meth anywhere between $5 and $10 for a hit. And so I think that it is still more expensive than fentanyl in many communities. But depending upon the community, methamphetamine may be more available. And therefore, it's all about availability and cost and demand.
Sure. Okay, well, I'm not seeing any other questions coming through. We sure do appreciate your time today, Dr. Lutz. Thank you
My
so
pleasure.
much. We will also, as noted in the chat, we will have the PDF of the presentation and also a link to the live presentation as well on our website as follow up in probably the next few days for the presentation itself, and then for a video a little bit longer than that, but it will be available through us. And just genuinely thank you. That was so informative, and I think we saw tons of great feedback as well. And we appreciate the role you play in our community and all the help you're giving for people. So thank you.
Thank you,
And
Justin. My pleasure.
thanks. With that, we'll hand it over to Megan, who's going to share some closing thoughts for the day.
All right. Thank you, everyone, for sticking with us throughout the entire day. It's been great to see so much participation throughout the day. This is our 5th year doing this, and I'm always just blown away by how much support attendees show each other, how much support our attendees show our presenters, and the resources that we're all sharing and collaborating on as we seek to improve our public health approaches to addressing overdose. So this was day 1. We have 3 more days of the series throughout the month. As a reminder, it is every Wednesday for the rest of the month. We do ask you to register for the other days that you plan to attend. So if I could have Alex or Justin pop that link to register into the chat box for you. I did put the survey link in there just a minute ago. So if you need a certificate attendance, you do need to fill out that survey. But if you don't need a certificate and just want to provide us with some feedback on today's sessions and the series overall, we would love to have you fill out that survey so that we can improve our sessions over the coming weeks, as well as for when we are planning next year's series. One final reminder, we were supposed to have another session at the end of today on medication overdose considerations for older adults. That has now been rescheduled for our last day, August 28th from 2 to 3 p.m. So if you were planning on attending that session, please mark down your calendars for August 28th instead. As Alex and Justin have noted throughout the day, we will be posting all of these recordings and the slides on our website landing page. We'll put that link into chat as well. And folks are always welcome to reach out to us over email. You can send us a message through Eventbrite or just email us directly, and we are happy to respond and help out in any way that we can. Thank you all again so much. I hope to see you all next week, and keep up the amazing work with sharing resources with each other and participating in these sessions so that we can all further our understanding. We'll leave this session open for about 1 more minute so that you can click on those links, but otherwise have a great rest of your week, and we will see you next week. Thank you, everyone. And I am seeing a question about surveys for those who might be driving or don't have access to the chat right now. I did send it out in an email through Eventbrite, so you should be able to have that in your inbox now. If not, please send me an email and I can send it to you individually. Thanks so much.